The Supreme Court's decision in Dobbs v. Jackson Women's Health Organization has had profound implications for people seeking reproductive health care. It's also disrupted medical training in states with significant restrictions on abortion. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Abigail Cutler, an assistant professor and associate residency program director in the Department of Obstetrics and Gynecology at the University of Wisconsin School of Medicine and Public Health. Dr. Cutler has co-authored a perspective article about ensuring access to abortion training for obstetrics and gynecology residents after the Dobbs decision. Dr. Cutler, what type of training in abortion care must be provided to OBGYN residents in the United States, and why is that training considered a critical component of their education?
Routine training in abortion care has been a core educational requirement of the Accreditation Council for Graduate Medical Education, the ACGME, for OBGYN residency programs since 1996. And that's because prior to the training requirement, the proportion of residency programs reporting routine abortion training was really low, like as low as 12% in 1992, which was a problem given that abortion is one of the most common reproductive health experiences for people capable of pregnancy. After all, 1 in 4 women will have an abortion by the time they're 45 years old. Currently, the ACGME states that training in abortion, and that refers to induced abortion, not just procedural management for miscarriage, must be integrated into the OBGYN residency curriculum as an opt-out experience. I think about 92% of residents reported some access to abortion training as recently as 2020, but what that actually looks like really differs depending on where one trains. So at minimum, abortion training involves teaching our residents skills in uterine evacuation, which can be done with medication or a procedure. It's really important for OBGYNs to know how to expertly and confidently evacuate a uterus, particularly in the first trimester, because that's when the vast majority of abortions happen. The needed skills are the same, whether caring for patients who've experienced a miscarriage or inducing an abortion, and are also necessary to have when managing complications like retained tissue or heavy bleeding that sometimes occurs at the end of a pregnancy. Comprehensive abortion training also includes hands-on experience in second trimester abortion care, often referred to as dilation and evacuation or D&E. And second trimester abortion care requires a slightly more advanced skill set. And as is the case when building any procedural skill set, exposure to high volume and experience with less straightforward cases is imperative to developing that necessary competence and confidence. And so for OBGYN residents who train under restrictions, whether because of state laws, institutional policies, a lack of able or willing educators, the education and training they receive in abortion care really can vary. In the case of teaching hospitals that can't or won't provide abortion services, some programs will, if they're able, send their residents to outpatient clinics like a Planned Parenthood to receive training. Other residency programs really struggle to get their residents any hands-on training at all. There are reportedly programs that attempt to satisfy the ACGME requirement by providing just a lecture or a video, and obviously that's not meaningful training.
So when and where did residents in your program typically receive abortion training before the Dobbs decision?
Starting in 2010, we saw a huge uptick in the number of abortion restrictions passed by state legislatures across the country, and Wisconsin was no exception. In the years leading up to Dobbs, we were subject to many restrictions in Wisconsin that made training our residents in abortion care, to say nothing of providing abortion care to patients, really hard. We had a 22-week ban passed, a 24-hour mandated waiting period, in-person counseling and ultrasound requirements, a parental consent law, and that's just to name a few. But the most consequential restriction passed by far was a state law that prohibits the use of public funding for abortion services and prohibits any insurance plan sold on the ACA marketplace in Wisconsin from covering abortion care. Many private insurance plans also stopped offering coverage for abortion. This means that the vast majority of Wisconsinites do not have insurance coverage for abortion in a hospital-based setting or anywhere else. So most patients can only afford to have their care, with limited exception, in an outpatient clinic setting like Planned Parenthood. So I say all that to explain that prior to Dobbs, we trained our residents in abortion where patients were able to access that care. And that was for the most part at Planned Parenthood of Wisconsin, where we taught residents how to provide medication abortion as well as uterine evacuation procedures into the second trimester in accordance with pre-Dobbs state law. And when Roe fell and the threat of this 1849 criminal ban shut down our clinics, we pivoted to figuring out how to get our residents trained out of state.
And in fact, in your article, you described the partnership that you and your colleagues established to ensure that your program's residents could obtain abortion training after Dobbs. How did you go about creating that arrangement, and what does it entail?
Building that partnership was the result of a lot of hard work and commitment from a whole lot of stakeholders here at our program as well as with our partner program. We were really fortunate to have committed program directors on both sides, faculty, department chairs, and institutional leadership who were able and willing and motivated to set up this experience for our residents because they recognized how important it was to their education and to their training and to the skill set of our future workforce. In terms of what our partnership looks like, our residents spend about 4 weeks at a time with our Illinois-based colleagues. They receive training in an array of healthcare settings, including the hospital and the clinic, and our program pays for their ongoing salary and benefits, as well as an apartment that we rent for them. And the effects of our partnership have been really significant. We were able to recover our lost procedural volume, which is not only important for ensuring that we remain an accredited residency program, but also crucial to ensure that we're graduating residents who will be able to confidently and expertly provide abortion care in their future practice. And beyond that, our residents gained really invaluable experience in learning what it can be like to provide abortion care to patients in a relatively unrestricted setting where abortion is by and large fairly integrated into routine reproductive health care.
So you talked about the financial costs for your program. What are the costs of the partnership for the host program?
Thanks for asking about that. Our piece alludes to the burdens that host programs shoulder, but it's not the focus of our piece. And while I certainly don't want to speak for my colleagues in Illinois or for host programs in other places, I do think, speaking broadly, that while our partners in unrestricted states may certainly derive professional and even moral fulfillment from training residents from restricted states, I think it's fair to say the costs are high for them too. Paperwork is equally burdensome. They must also secure buy-in from their residents, their faculty, their institutional leadership. Training an entire additional cohort of residents from outside your own program is a big lift, and that's work that's generally uncompensated in terms of time and money. There's also the concern about diluted educational experiences like procedural volume for their own residents. So it's a lot of extra work for unrestricted states to shoulder, and all in addition to the huge influxes of patients from hostile states who are seeking care from them. In my opinion, relying on the so-called quote unquote blue states to ensure we're training our future workforce is not a solution for the long term. I have a complex family planning colleague who often says there are no safe states. And by that, she means we cannot take abortion or abortion training for granted anywhere. I know folks in Massachusetts, one of the least restrictive states, who have struggled to access even medication abortion from their OBGYNs who tell them, we don't provide that, or my hospital won't let me. And that's just pills. You can imagine how difficult it is for people to access a needed procedure. So ultimately, that's the take-home message of this piece, that these partnerships are extremely valuable and we are so grateful for them. But at the end of the day, it's really incumbent upon institutions everywhere to assume responsibility for removing barriers and restrictions to abortion care and training in their own settings.
So finally, and in that regard, have you and your colleagues communicated with residency program directors in other states that have significant abortion restrictions? How have other programs addressed this need to continue to provide training?
I am aware that more than 130 OBGYN residents from 8 restricted states have participated in out-of-state training opportunities, mostly since Dobbs. There are, I think, 18 unique training collaborations that have been established between restricted and less restricted states. And that's a big help given that 23% of OBGYN residents currently train in states with abortion bans. But what those training experiences or partnerships look like, I think, really varies. We know from speaking to OBGYN residents who have participated in these experiences, those who have traveled for abortion training, their experiences are overwhelmingly positive. And that's a testament, again, to the dedication and commitment of our colleagues in unrestricted states. But like we write about in the piece, and as I just mentioned, these partnerships also have costs and the barriers to entry are really high. And that's true even under the best of circumstances, like when you have institutional buy-in and support, as we did. Many, many programs, especially those in restricted states, don't enjoy that. They don't have institutional buy-in or support. I recall talking to one residency program director from a nearby state not long after Roe fell. She was in the early stages of trying to set up a program for her residents, and she was asking about our experience. And I still recall the total frustration in her voice as she described the sheer number of barriers she was facing in her own efforts. And she sounded totally worn down by it all and was just trying to do the right thing for her residents and her program.
Thank you, Dr. Cutler.